Good morning. My name's Alan Weil. I'm Editor-in-Chief of Health Affairs. We're so happy to have you joining us for today's event on aging and health. It's part of a series that we've been able to produce of articles with support from the John A. Hartford Foundation, and this event is supported by them as well. In addition to thanking them for their financial support, I do want to acknowledge Jonathan Bohr, who's the editor at Health Affairs, who handles all of these papers, and I know he's here. There he is. But these things don't happen on their own, so I want to make sure we acknowledge the work that he does. What we publish in this area is what we call a series. That is, it's papers that appear and blog posts that appear over time. And what I like about this topic is that it's one of these cross-cutting issues that brings in elements of so much of what we publish in the journal and discuss in health policy, but it brings them in around a particular theme. So of course, you can't discuss aging and care for older adults without looking at issues of healthcare system organization and delivery, issues of the workforce, particularly the relationship between informal and formal caregivers. And so there's a whole rich area having to do with how care is organized and delivered. I don't think there's any issue in healthcare, but this certainly is not one where you can have a conversation without talking about financing. It is so much of what the organization delivery is guided by what we pay for and how we pay. And there are many people who've been working many, many years to try to better align financing with what it is we hope to achieve through our care delivery systems. This topic brings up important issues of equity, which I actually don't think have received as much attention over time. There's so much unmet need when it comes to services for older adults. We tend to focus on that, but it turns out there are also significant inequities in who does and does not receive care and appropriate care. And then, of course, this is an area that is ties to everyone's favorite word in healthcare. I think it's actually everyone's favorite word at every conference, which is innovation. There are terrific innovations going on. There are great ideas out there, but we need to learn what works and what doesn't. Turns out that not all innovation is good. But this is an area where there's some terrific ideas. We need to build the evidence base, and we need to figure out how to replicate and extend and stretch beyond the early thinking. So all of these dimensions are dimensions that we try to cover in the papers and blog posts that we publish, and not surprising, they will all come up today. The way we're organized this morning is we have 3 presentations from authors who have papers in the journal. I've asked them to not simply present their papers. Their papers have been out for a few months at least, and hopefully, if you're here, you've had a chance to look at them. I don't want you to just sort of feel like you're getting a rehash of what's already been published, although it's really interesting stuff. That wouldn't be such a terrible way to spend your morning. But I have asked them to go beyond the boundaries of their papers and speak more broadly about the issues that those papers generate, and get a little broader perspective. I'll have a little conversation with them. We'll bring in some of your questions, and then we'll have a second panel that will be a broader policy discussion, some reaction to the papers, some more forward-looking about where we go from here, and we'll be wrapping up at noon. So that's the order of the day, and that's why we're here. And it gives me great pleasure then to have us begin the session today with Terry Fulmer, the president of the John A. Hartford Foundation. She's an elected member of the National Academy of Medicine, formerly distinguished professor and dean of health sciences at Northeastern University, was the Erland Perkins McGriff professor and dean of the New York University College of Nursing. Really an exceptional career and an outstanding leader in the field, and it's my pleasure to introduce Terry Fulmer.
Alan, thank you so much, and welcome to everybody who's here with us today in the room, as well as all the people online today. This is an extraordinary panel that we'll be hearing from today, and I'm just so pleased to be here. And our foundation is grateful for the partnership we have with Alan and his exceptional staff at Health Affairs. When Health Affairs writes something, it matters. People pay attention. and the work we're talking about today deserves very strong attention. So I'd like to also specifically thank Alan's team, who are so terrific, editor Donald Metz and executive publisher Jane Hebert-White. Without them, this work doesn't happen, so thank you. We have a very impressive list here today for today's discussion, many of whom I've had the privilege of working with and who are important partners with our foundation, and we're thankful to all of you for doing this important work. And before we get going today, I'd like to just comment a minute about the John A. Hartford Foundation. So the John A. Hartford Foundation, funded in 1929 with A&P grocery store money. And John and George Hartford said that what we should do with that money was do the greatest good for the greatest number. And that's what we try to do every day. And so it's with you that we make that happen. We are really pleased that for over almost 40 years, we've been focused solely on improving care for older adults, creating leadership for those who want to improve care for older adults, and improve the science of the care for older adults. So we thank you for that work. Our three current areas are the following: creating age-friendly health systems, and so many of you in the room are already helping us get that accomplished. Improving care for those with serious illness and end-of-life care needs, and supporting the 40 million family caregivers out there who are helping us get to the next phase of what our country will need to do for our older adults and for the families of older adults. Here in Washington, where there are many voices angling to be at the forefront of the healthcare policy conversation, Health Affairs has long been recognized as the authority, and there's no mistake about why we're here and why we partner with Health Affairs. This is why we're delighted to support Health Affairs in this series, and our work is powered by a simple but critical philosophy that older adults deserve the best care possible. We like to say, please demand age-friendly health care, because you deserve age-friendly health care. And so join me in that mantra. Health Affairs plays an important role. Alan and team, you're critical for this influence, and I'm just delighted to join you today. Thank you for being here.
So I know you sat down, but I think we're going to call up our panelists.
Yes, we are going to call up our panelists. And so now let me turn to our program, and please invite our panelists.
Where are you all? Come on up. Don't be so shy. Okay, we are going to hear from the three authors who I mentioned. Brad Stuart, Chief Medical Officer of the Coalition to Transform Advanced Care, or CTAC, was the architect of Sutter Health's Advanced Illness Management Program, which you will hear more about, so I won't spoil the fun. Next to him is Tamara Konetzka, Professor of Health Services Research in the Department of Public Health Sciences at the University of Chicago, also with an appointment in the Department of Medicine section of Geriatrics and Palliative Care. And Katherine Ornstein, an epidemiologist and assistant professor in the Department of Geriatrics and Palliative Medicine and the Institute for Translational Epidemiology at the Icahn School of Medicine at Mount Sinai, also the director of the Institute for Healthcare Innovations at Home. And we will begin with Brad. I think it's preferable.
Yes.
We don't demand it.
Well, thank you, Alan. And I'm assuming I shall control the slides here. There we go. First, I want to express extreme gratitude to Alan and the Health Affairs staff. I have been trying to get this paper into Health Affairs for I can't tell you how many years, but Alan, you and your staff, especially Kathy Haddad, really improved what was just a pile of data to begin with, and I'm very grateful. I'm going to talk about, and Alan, you asked for it, what's in the paper. I'm not going to inflict a lot of the data on you, but I am going to talk about the principles behind what we've been trying to do for a quarter century, which is set up a different kind of care delivery for people who are really ill, and most of them are also really old. So let me go back here. We're going to talk about advanced illness. Those of you who are familiar with CMS and their newer developments know that they're coming out with primary care first and serious illness payments. And I'm not sure how deep we're going to get into that. I'm not going to do that now. But serious illness and advanced illness are different. Advanced illness is a subset of serious illness. Advanced illness happens when people have one or more conditions that cause their health to decline, usually in an irreversible way, and their treatments, just as a doctor, you don't get the bang for the buck that you were getting. It's a very small number of Medicare beneficiaries, but a lot of their cost. And you'll see that 25% figure come up again because Medicare spends 25% of all its dollars on care in the last year of life, and that's roughly where this population lies, last year or two. The care for this population is driven by how sick they are and by their calls to 911 because they don't have any alternative. Their preferences aren't elicited or recorded very often. Advanced directives have not worked that well, and so there's lots of admissions, and the services that we do have in palliative care and hospice are way underutilized. If you look at the continuum of care for people who are ill, you can start with primary care through chronic care, complex care management. Then you have advanced illness right upstream from hospice. That transition from advanced illness to hospice has been difficult classically, and it still is. People get more hospice. There's more patients coming into hospice, but they're coming in a lot later than they should, and many of them come straight from the ICU into 2 days of hospice at home before they die. That transition is critical. Serious illness, as Medicare is talking about it, includes a very much larger and not as sick upstream population that have complex chronic illnesses that are poorly managed, care is fragmented. Medicare wants to try to fix that. But contrary to what actually we recommended in our article, they are not going to focus on the sickest of the sick. They're going to focus on a much larger population, and that has not resulted in savings or excellent clinical results in other Medicare demonstrations. Failing to focus on the sickest of the sick is often, a shortcoming of Medicare demos, and this may be no exception. This is my favorite financial chart. It has to do with the amount of money Medicare spends per month, per Medicare beneficiary, per individual, each month leading up to the last month of life prior to death. And as I mentioned, 25% of all Medicare dollars go into this whole last year. That last bar, and you only see 6 months worth of bars because the first bar on the left represents everything upstream. Medicare spending is very relatively low until you get very near the end of life, and then you see a ski jump. If you look at the last bar, you have to take my word for it, but the dollars represented by that bar in Medicare spending, there we go, are a third of that entire last year of Medicare spending. 1/3 of 25% is about 8%. So we're pushing 10% of all dollars Medicare spends on care in the last month of life. And not only that, 80% of it, the red part of the bar, is for hospital treatment. This data is a little old now, so things are changing. But everywhere we've gone and helped people analyze on the state level, the individual hospital level, you see this exact same shape of spending as death approaches. That's why, if you're aiming for savings, you want to treat the sickest of the sick, because a lot of the savings accrue from one simple thing, simple but not easy, and that is preventing or avoiding this revolving door cycle of hospitalizations that people tend to undergo right before they die. It's very still distressingly common. All other spending, home health, hospice, everything else actually goes down in that last month, although I think the blue bar these days is a tiny bit higher. Sorry, we're skipping 2 slides here. Advanced illness management was a solution we tried to come up with back in the late 90s at Sutter Health, a big system in Northern California. I want to emphasize, and I'll come back to this, if you're an integrated or integrating, there is no such thing as an integrated health system. We're all integrating, but if you're a big system, you can more easily do what I'm going to describe. But you don't have to be vertically integrated, and I'll come back to that. You don't have to have one corporation owning everything. Medicare is trying to incentivize groups coming together and collaborating to do the kind of work that we started back then. The key clinical intervention is, I'm a physician, primary care, internist, times like pushing 50 years now. We discovered, doing hospice for a quarter century, that nurses and teams led by nurses can basically do what I would do on a house call. And I don't want to offend any independence at home advocates here, but I'm sorry, we just don't need doctors doing everything. We can have teams of people that the doctors work through to deliver care. So what these teams do is provide care management, and especially they sit down with patients, families, and caregivers and do advanced care planning. Take the handoff from the initial conversation that the doctor may or may not have and conduct those conversations at the patient's own pace, which is very helpful. Patients appreciate that, and they actually make plans. In 2013, we got a first round Healthcare Innovation Award from CMMI of $13 million to run this program out across Sutter's 24 hospital system. And there's a couple of numbers there. The intervention was very successful, actually surprised us in reducing hospital days, especially in the last 30 days of life, that last big red bar. And total cost of care was reduced very significantly. In 2017, we got to the point where we had 3 FTEs, 3 work equivalents of physician time managing patients across 19 counties, over 2,000 a day. And altogether, we've had, Sutter has had, I'm not there anymore, over 30,000 patients have come through this program. 60% of them have not gone back to the hospital and have gone to hospice. And then finally, this year, you may know that CMS announced serious illness payments as part of the Primary Care First initiative, and those payments are based in part on this program, which is kind of cool. I won't comment on the payments. So the lessons we learned overall were advanced illness is important. You can really help ease this huge shortage of docs we have now in palliative care using these teams. Wraparound care management just means that you start with post-acute care, take people out of the hospital, manage them at home, and it becomes pre-acute care, and you can keep them out of the hospital because that's what they want to do. Virtual integration I mentioned, it's the same as vertical integration, except nobody owns everybody. Collaboration happens, and these payments, I think, will help that. I want to comment very quickly on patient-centered care. It's great, but it's short-sighted in this population because when you're a doctor and you see a sick person and you think patient, that takes you down a road that is a loser because many of these people need person-centered care so they can express what they want as people, and it's often, I don't want to go back to the hospital, but they have no way of doing that unless they're supported. And when you bring support to them, which is really what moving care out of the hospital to the community is all about, this is what you can get. And finally, there's a reference down at the bottom to a paper we also published this year. Underlying all this is the emotional fact that we have a very tough time in medicine not equating losing hope with this point where treatment doesn't work so well anymore. Everybody loses hope. It's a huge barrier to doctors telling patients the truth and patients getting good end-of-life care. But hope doesn't go away, unlike what doctors have been shown to think. Hope evolves from hope for cure to hope for a lot of other things that are a lot more personal, and person-centered care can get you there. So I encourage you to read that article. We'll be doing a symposium at Harvard this next year on the evolution of hope in serious illness. And thank you.
We're working on the power, but
Well, I can start talking while we figure that out.
yeah, let's see.
Okay. Well, good morning, everyone. I'm Tamara Konetzka from the University of Chicago. I'd like to thank the Hartford Foundation for funding this series, and I'd like to thank National Institute on Aging for funding my work in this area. Let me start with the big picture context. Sorry. Elderly people who need long-term services and supports. Sorry, I really want those slides. Right. Okay, I'll just start talking. As many of us know, there's been a long-standing trend over the last couple of decades to provide more home and community-based services to elderly individuals on Medicaid who need long-term services and supports. The motivation behind this trend has been taken as sort of self-evident, right? That on the one hand, everybody prefers care at home. Nobody really wants to move to a nursing home. And on the other hand, it may be cheaper. Institutions are very expensive places, and if we can reduce the number of people who are getting care in institutions, then that should save money. As I said, this trend has been continuing such that now more than half of Medicaid dollars that support long-term care services and supports go to home and community-based care. But that metric in itself has almost become the goal, right? Among policymakers and advocates, a higher percent HCBS is always seen as better. Oh, great. And I think there's good reason to think a little bit more carefully about that assumption. One, why did I lose it already? First of all, HCBS inevitably involves a lower intensity of care than a nursing home. So for very sick individuals, that may be risky. Second, HCBS inevitably involves shifting some of the care burden onto informal caregivers, usually family members who may not be trained and may or may not welcome that burden. And finally, just as we see in other sectors of the healthcare system, there's a potential for disparities in home and community-based care. So even if we see good outcomes on average, they may not be equitable. So I've been arguing for a long time now that it's time we take a closer look at HCBS outcomes and equity. And I have sort of large mixed methods projects that's doing exactly that. And the article we had in Health Affairs a couple months ago is just a small initial piece of that project. So I'll give you a few highlights from that study. In this study, we looked at Medicaid claims data from 2012. So we have a national sample of elderly individuals who are duly enrolled in both Medicare and Medicaid. And this gives us a sample of 1.6 million people. And we wanted to look at a couple very simple things: their use of services by care setting, their spending, and one measure of outcomes, hospital admissions. Yes. Okay. Well, I'm just going to highlight, instead of showing you the graphs, I'll just highlight a few of the results. And the graphs are in the paper anyway, so you can look at them if you haven't already. So one main result was that even though people who are getting care in nursing homes are sicker than people who are getting HCBS, we see that hospitalization rates are higher for people in HCBS, right? And this is especially true among people with dementia. So that's some cause for concern. Another main point that we found was that blacks relative to whites, or really any racial and ethnic minority relative to whites, are one, much more likely to use home and community-based services than to use institutional care at any point during the year. So there's these differences in use that may or may not be a good or bad thing. But then when we looked at spending and outcomes, we found that among people who use home and community-based services, we spend much less on HCBS for blacks relative to whites. At the same time, blacks are hospitalized at much higher rates than whites. And this is true whether you look at avoidable hospitalizations, potentially avoidable, unavoidable, all hospitalizations. But that difference in spending on hospitalizations doesn't even offset how much less we spend on HCBS for blacks. So we spend less on HCBS for blacks than whites, and we spend less in total, despite the fact that they're getting hospitalized more often. So these were a few key highlights from our paper, which admittedly was completely descriptive. We adjusted only for sex and age. And so one key question that comes out of this is, what do we take away from this? And so I'd like to make a couple of points about implications and the broader discussion. Yeah, maybe I can just glance at it for a second and remember what I was going to say. So first of all, we need to investigate why we found what we found. And that involves, sort of looking at the causal mechanisms and taking a deeper look at what's happening. I think there are a couple of plausible stories. One is that this is a function of sort of local area characteristics, right? That areas in which racial and ethnic minorities are more likely to live just have a poorer health infrastructure. And that may be access to good home and community-based care. That may also be access to good primary care and other kinds of healthcare needs. It also may be that we're simply underfunding home and community-based services, especially in certain areas. The second key takeaway from our work so far on this project is that evaluations of home and community-based care really need to start considering all the costs and benefits associated with providing care in a home-based setting, right? So this counts not only the actual costs of home and community-based care, but we have to look at other payers beyond Medicaid and count the costs of hospitalizations to Medicare, for example. This also means we need to start counting the costs to informal caregivers, right, who I said inevitably have a greater role in home and community-based care than they do in institutional care. And there may be costs and benefits to caregivers that we should be counting. And finally, the sort of indirect costs of hospital transfers in terms of the health of the recipient as well. On the other side, there's lots of benefits we're not really counting or quantifying, like the benefits in terms of having people's preferences met to stay at home. So we really need to start taking a broader look. It's hard to do, but a broader look at the costs and benefits. The final thing I'll say about our results and this area in general is that, instead of just thinking about this metric of more and more home and community-based care, it may be time to return to more of the notion of trying to find a way to get people the right care in the right place at the right time. And that may sometimes be home and community-based care, sometimes that may not be home and community-based care. In the end, I'm certainly not advocating for more institutionalization. Nobody wants that. But I think our point underscores that if we really want to do home and community-based care right and ensure adequate outcomes and reduce disparities rather than exacerbate them, then it may cost a lot more than we think. Thank you.
That was very well done. given the technological difficulties, I hesitate to pass it over to you.
I know, I'm bringing my notes because, I don't trust it, and that's okay, but thank you so much. And I want to thank the Hartford Foundation as well as the NIA for supporting my research in this area. And I'm presenting just one study that calls attention to the need to prioritize support for family caregivers. The title of my study gives really everything away. And as we move away from nursing home care, we are increasingly relying on caregivers. Family caregivers are involved throughout the course of illness, and this includes the end-of-life period. And the end-of-life tasks become more extensive. As you can imagine, we're really thinking about decision-making issues, especially around institutionalization potentially, symptom management, and families, not surprisingly, can experience more negative outcomes in these situations related not just to their mental and physical health, but sort of financial strain as well. So the goal of this study was to really try to understand the experience of caregivers relative to who is supporting them. And we focused on the end-of-life period. We also focused on spouses here, but I would like to point out that spouses are really the minority of family caregivers in this situation. Dare I try? Oh, okay. So as you can see here, and as my title really gives away, what we found in the first bar you can see here in the blue is spouses are frequently caregiving on their own when they're caring for a dying partner. The blue portion of the bars represent the solo caregivers, and by solo caregivers I mean that no one is helping them. No paid help, no unpaid help. And this phenomenon existed regardless of caregiver gender, and you can see the different bars represent different subgroups. And while of course there were more female caregivers serving alone and a greater percentage of them doing so, 47% of male caregivers were acting alone. And I think we need to take pause and really think about some of our traditional gender roles around caregiving, at least, in this situation. Solo caregiving was also even common in the context of dementia, despite the unique challenges of that care situation and known increased burden for families. Of note, this is not merely a phenomenon of families being more geographically dispersed. 59% of solo spouse caregivers have children who co-reside or live within 10 miles, yet they are providing care alone. Wow, okay. Spouses are really working longer hours, and these hours are more emotionally and physically demanding, again, often in isolation. This graph here is showing the activities of the solo caregivers. They are working more than 40 hours a week alone, and in the context of dementia, this is more than 60 hours a week. And here we see different tasks that they are engaging in. We see that a third are assisting with bathing. 10% are assisting with toileting, and as you see with the red bars, there are even higher percentages among those with dementia. We should worry about these solo caregivers. They're vulnerable. They themselves tend to be older, in poor health, and they're facing the challenging emotional and financial experiences of widowhood. So as we really are thinking about a shift towards community and home-based settings for individuals, I think we can agree that this is a key strategy. I'll echo my colleagues, we're not pushing for institutionalization, but we certainly have to take pause and ask to what extent this may confer additional burden on family caregivers and how best to mediate this impact. We also need to remember that all days at home aren't necessarily good days. It's not just quantity. A day, for example, with untreated pain is a very difficult day for a patient and their caregiver. So home and community care must be of high quality and meet the person's needs and the family caregivers. I would also say that caregiving is challenging for all families, but it disproportionately may affect vulnerable groups like those who are lower income, leading to impoverishing the next generation through missed education, work, opportunity for advancement. So I, of course, don't have one simple solution to this. I would say that the Raise Family Caregivers Act, calling for a national strategy to support caregivers, is extremely promising, although there's not funding supporting that. I want to highlight a few areas, and I hope we can discuss these moving forward, which is caregiver assessment itself is particularly critical. Availability of family does not guarantee support. Even when adult children live close by, they are not not necessarily engaging in care. Additionally, we found that 9% of spouses themselves were not engaged in any direct support, likely due to their own poor health, but it also could be a preference of the patient and the caregiver. So it's an important reminder that providers need to recognize, assess, and address the caregiving situation, which is likely very dynamic. While a spouse may be available to help, this may not at all be their preference. It also may not be the caregiver's preference. Recent changes in Medicare Advantage offering non-medical benefits to enrollees is benefiting caregivers, and I think a growing number of plans being able to cover caregiver support, respite, training, and counseling is promising. And I would also say that there's a pressing need for the widespread availability of palliative care services for the seriously ill, patients living in their home. For many people, the availability of non-hospice palliative care outside of the hospital setting is really limited at best. We're changing, hopefully, but really caregiver support for the serious ill needs to be available regardless of prognosis. Expansion of community-based palliative care is critical for older adults and their caregivers who wish to remain at home, and certainly passing Palliative Care and Hospice Education and Training Act will be critical to expand the palliative care workforce. And in general, I would say that we have to broaden the availability and diversity of supports that will allow families the ability to balance work and caregiving responsibilities. And as we are probably all aware, few Americans have access to good paid family leave. Families want to be involved in the care of their loved ones for the most part, but we need there to be reasonable options to allow them to do so. So thank you for your time, and I look forward to the comments from our panel as well as everyone here.
So I'm going to ask a couple of quick questions, and then Terry, maybe you want to think of some too, and then we'll open it up. But let me just quickly run through for each of our three speakers. Brad, you mentioned targeting, and I just wonder, a common comment about end of life is that you can only count it after it's happened because you don't know exactly when you're approaching end of life. So looking at the data retrospectively is very interesting, but it doesn't necessarily line up with how we live and experience. So can you just say a little bit more about because you were very clear that these resources need to be targeted. Can you say a little bit more about the confidence we can have in our ability to target?
Well, it depends on who's the we that we're talking about, who's doing the determining. It's been shown that clinicians are fairly accurate, not super accurate, in predicting when patients are getting, within a year or so of death. And the good old-fashioned palliative care eligibility question, if you ask a doctor, if you ask a hospitalist or an intensive care doc, would you be surprised if this patient died in the next year? And they say, well, no, I wouldn't be surprised. That turns out to be a pretty good screen. And there are numbers that you can apply. Medicare is going to try to do that with HCC codes and hospitalizations. I really have my doubts that claims-based data like that is going to give us a good population. But we found that over 75% of the patients that were instructed by us, the clinicians referred us patients that were appropriate. 75% of referrals we took, and we screened out people that we did not think were declining. So docs know when patients are going downhill. Unfortunately, referral-based care is not something that so far we're going to see with these new payments from Medicare.
Tamara, as someone who ran a Medicaid agency, admittedly more than 2 decades ago, I can affirm this notion that the goal was more HCBS, and we didn't look underneath that a lot. So I think that's a really important premise to the work. I am struck, and you were very straightforward about it, this is observational data. and it's old and it's limited just because of what you're trying to study. So my question to you is, given the data limitations, you're looking at a pretty complex phenomenon. What questions do you think are answerable next? Because I think you've shown a spotlight on a really important topic.
So I'll answer that in a couple of ways. First, I mentioned at the beginning that this initial descriptive analysis is part of a broader mixed method study that we're doing, and so I think some of the answerable things are things we're trying to do right now, and that is using better models to try to assess what the reasons are behind some of the disparities we find and the differences in hospitalizations. And so some of those things can be done. For example, we looked at, if you sort of control for zip code, at least, that's what we can do right now, do these disparities still exist? And they do. So it's not just about the sort of ecological problem that, for example, blacks live in different zip codes than whites, right? These problems exist within zip code as well. So certainly econometrically, one can get a little bit closer to figuring out what's going on. We also have a large qualitative component, and even though I'm an economist and I don't really like to talk to people and I just want to see data, I think it's essential to actually find the backstory to the numbers that we're finding, right? And so we're also interviewing caregivers, so specifically trying to get at how some of these policies influence their decisions, and in turn how their decisions influence their lives, right? So we're doing that across states. And so I think we can get at some of those underlying reasons that way as well. There are going to be parts of it that are just sort of intractable, right? So really discovering why these disparities exist and how to solve them is a much longer problem, but I think we can make inroads, even given the data we have. We're using 2012 Medicaid data because that's what exists for the entire country, although we also looked at it in 2005 and a subsample in 13 and 14, and things don't really change that much. These are sort of underlying fundamental problems.
Thank you. And Katherine, I'm struck in part because we use it for resource allocation. We've put a lot of effort into assessing the needs of the patient, the person whose health is declining. What do we know about assessing the capacity of the caregiver, including the preferences of the caregiver? And I think you importantly pointed out that both the caregiver and the spouse may have preferences in one way or another. How good are we at figuring out what the capacity is on the caregiving side?
I think we're really not that good, is the short answer. The longer answer is, I think we try. But frankly, if an EMR even notes that there is a caregiver and has a phone number that works, that's pretty good, I think, from the clinician's standpoint. I think the reality is, often there's not just one caregiver, there's multiple people. I'm my dad's caregiver, I'm busy right now, who else is there? We have to really make sure we know who those people are. And again, I think what we're seeing is there's so many assumptions about care. I think the clinicians that go into the home, they see this because they think, oh, there's a spouse. They meet the spouse. The spouse actually also needs care at home. So I think I think it's not easy to do because it's dynamic. Right? A spouse may have been an excellent caregiver and they may have, really done well in that capacity, but then that spouse may get sick. There may be a daughter who's very supportive, and that daughter may move across the country. So I think we really have to systematically look at this, and I think what's also important, I think the concept of caregiver preference and patient preference. I think when we really think about different tasks, the kind of tasks that are important for nursing home placement, such as helping with toileting, we have to think about, does someone want their daughter helping them with that task? And I think that, we can't assume that someone's comfortable with that, let alone trained. We really need to think about what do they want to do, and for their relationship, that we have to really think about the dignity of the patient and the caregiver.
Great. Terry.
Thank you, Alan. Those were so interesting as a collection of papers and speak to one another's issues in a way that helps us all get our heads around this today. I was thinking about the underlying theme, and that is discontinuity of care across settings, which is staggering. And I have a couple of questions about that for us and maybe for the panel as well. As a nurse, one of the things I say to people who are at home and very, very sick is, can you imagine a moment when you would not call 911? This seems to be a shocking question to ask people, and whether they are rich or poor. And so I want to know if anybody's thinking about that work. And the second thing is thinking about the opportunities for robotics and what we can learn from other countries like Japan. So are you thinking about either of those elements? And does anybody, Brad, do you want to start?
Sure. Well, let me start with the second one first. I think I'm a doc for a long time, and I'm a clinician, so I have not been a fan of high tech until recently. I think telemedicine, we have to find ways of helping our workforce reach out. And so, being able to monitor people at home, communicate with them has been a godsend, and it's going to really move us forward. Robotics is another area where it's already been shown that if you know how to create a robot that has some kind of ability to read your face and converse with you, you have a whole new segment in the workforce to care for people with dementia. Dementia patients love it. And I think it's fantastic, and I think it's going to grow very rapidly.
I appreciate that. Do either of you have ideas about 911? And you can pass, because I have a second follow-up.
Let me
you go
comment
ahead,
on
please.
People call 911 because of one emotional factor, and that's fear.
Right.
They're scared. And I just came from West Virginia, where a very good friend of mine lives out in the woods with his wife who has cancer, and they have been calling 911 until we were able to get hospice finally involved, and now they don't. We all want to continue to maintain the kind of life that we have, no matter how sick we get. We want to stay independent. That's the American way, for better or for worse. So, once you can put people in the home, and I don't think it's that difficult to do once you create the infrastructure, which means the social work, the nursing, some spiritual care, and windshield time, you can give people a lived experience of being supported at home, and very rapidly the fear level drops, and they call you before they call 911. And it doesn't take that much work or money to do that. And I think that's the next big step that we need to make.
Right. And so supporting family caregivers, one of the things any of us might do is practice that question with them. And so your comment, Tamara, what did you want to say?
I wanted to answer, not about the robotics, but I wanted to say one thing about the international comparisons and what we might learn. So, as most of you probably know, there are countries in Europe, especially where there is a more structured long-term care insurance system, in Germany and France, for example. And in Germany, the example that I know best, they do encourage home and community-based care. They have, a large proportion of people receiving home and community-based care. And the big difference, other than providing funding for it, is that they have an enormous amount of caregiver support and training. Right? So if you're going to receive funds for home and community-based care, you can pay family members out of those funds, and those family members receive training and regular in-home assessments and sort of ongoing monitoring. And that, to me, I'm sure Catherine would agree, is an essential difference in making home and community-based care successful.
And I do want to give a shout out to the National Institute on Aging that is focusing so heavily on support for family caregivers right now, particularly for those people with Alzheimer's.
Yeah, and I would just echo those comments and say that the caregivers have to be educated, and not just the family caregivers, also our formal caregivers. They often don't have adequate training, and they're told to just call 911. That's what they do. And so I think we really have to make sure that they are educated and that they're working together as part of the healthcare team so that they can handle these situations. I would also point out that some of the work that we're doing in our home-based primary care program involves community paramedicine. So that's a way of, instead of calling 911, we sort of have that option. But it really requires educating the families so that they understand these options.
Do I have time for follow-up or not?
Of course.
The second group that we're missing in the narrative is the public health system in the United States. And so Trust for America's Health here in Washington has been doing some interesting work linking the area agencies on aging with the public health system. There are 3,000 public health offices in the United States which could be activated to be a part of the solution. And so I wonder if any of you are working with your public health offices. I would suggest probably not yet.
Oh, no, yes.
Good. Tell us about it.
Well, I do a lot of that work because my wife is a public health nurse.
There you go.
So she would come home. She supervised the nurses in our county. I live in Sonoma County in Northern California. She supervised the public health nurses, and that included all the work with adult protective services. Wonderful. She would see the worst of the worst and the poorest of the poor, and she would come home at night and just have to unload. Every dinner table conversation was about cases that you really don't want to hear about. The most difficult cases there are. When I was at Sutter Health, I tried very hard to get the executives of the health system to actively reach out and collaborate with area agencies on aging and public health in the communities that Sutter serves, because everybody's now trying to do the same thing. All of the public health people are trying to keep people at home and out of mostly nursing homes, and we were trying to go out and keep people out of hospitals. We're all doing it, and yet we never talk to each other. So one big policy step would be to incentivize healthcare delivery services actively collaborating with public health and area agency on aging. That would be a huge step forward.
And I do want to recognize that Don Wright at Health and Human Services, along with Lance Robertson at the Administration for Community Living, are very intensively talking about this right now, so I'm optimistic. And sometimes when we think that a conversation is old, it comes back again in a really important way. So thanks for saying that. And as a nurse who has two aunts who are public health nurses in Herkimer County in the Adirondacks, that's exactly right. So thanks.
I just want to follow Terry. You used the word discontinuity. The one that came to my mind was, it's not quite as fun, but it's sort of balance. I'm struck that undergirding almost all of these comments is this notion that we have tended to think of service locations in categories in very separate ways. So you're in the home, or you're in the community, you're in an institution, you have family caregivers, right. And all of these are much more heterogeneous. And there's a lot more movement across them, which is part of the discontinuity. Right. But there's also again, it goes back to sort of organization and financing. We fund and think of each of those differently. We try to figure out where you belong, and we try to support you in it without acknowledging either the heterogeneity within or the need sometimes to move across. And that's a lot of what all of you are both finding and trying to address. I think I can sneak in one question here, but probably just one. So here, I'll bring it.
Really nice panel. Brad, I had a question about your CMMI demonstration and the nature of the care management that you described and the coordination of it. And it comes from sort of two sources. One is a recent personal experience where my mother passed away, and the other being a project we've been doing with the Gordon and Betty Moore Foundation around developing a model for integrating behavioral health into serious and advanced illness care. So the two questions are, number one is, what we found toward the end with my mother was that we had too many cooks, that the combination of hospice, her long-term care aide, assisted living residents, plus family caregivers got very, very complicated. And there was no real locus of coordination. And there were some instances of discoordination and things falling through the cracks, and it fell to the family caregiver to kind of administer it, even though the resources were an embarrassment of riches. And so I'd be curious about how you dealt with that in the demonstration. Number two, whether, to what extent, you incorporated behavioral health into the care management process in the demonstration.
Great questions. Thank you, Alan. Well, behavioral health first, we definitely included it, and the question always is going to be, who are you going to pay to do that? My favorite interveners are social workers, although you can hire psychologists, but so much of the work that we do with dual eligible, say, patients who are on, say, Medicare and Medi-Cal, lots of behavioral health, mental illness problems, drug problems. You gotta, I think, have social workers on your team to help sort that out, and you have to give them priority and make them care managers. And I think that goes a long way to help. Nurses can do that as well. I don't think the training is there quite as much, but for social workers it definitely is. And I think behavioral health is an immense topic because it makes the care management much more challenging. Back to the first question, we, in our intervention, we trained our care managers to sort of be air traffic controllers. They would come in and they would take the embarrassment of riches that you were describing and help organize them. Not only that, they would organize the primary and specialty physicians because everybody's seeing 9 doctors and taking on average 18 medications. So somebody has to come in and sort that out. And I think if you recruit, train, and hire and train staff who know how to do that and are good at it, you can sort a lot of that out. Policy-wise, I think one of our jobs coming up very soon is to begin to sort out the redundancy that we have, because that's really what you're talking about. It's fragmentation and redundancy. We have a lot of people with overlapping job descriptions, and that needs to be sorted out.
Great. Okay, well, this has been a great way to start. Please join me in thanking our presenters this morning. We're going to go straight into our next panel without a break so that we can keep the momentum going. It's up to you. You have a... Thank you all. We have a really terrific panel, I have to say. We're lucky to have attracted such a thoughtful group to join us for a policy discussion, so you are in for a treat. As they're getting seated, I'll just give you some quick introductions. Bruce Leff, a professor of medicine at Johns Hopkins University School of Medicine with a joint appointment in the Department of Health Policy and Management in the Bloomberg School of Public Health. Hwang, director of the Center for Consumer Engagement in Health Innovation at Community Catalyst, a primary care physician, former director of healthcare policy and strategy for the Commonwealth of Massachusetts Executive Office of Health and Human Services. Tim Ferris, CEO of Mass General Partners, Mass General Physicians Organization. That was a bad slip. I try not to make that one again. Well, there you go. Can't take that one back. Formerly medical director and senior vice president for population health at Mass General and Partners Healthcare. Jennifer Wolff, Eugene and Mildred Lippitz professor and director of the Roger Lippitz Center for Integrated Healthcare at Johns Hopkins University. I've asked them each to just give a few opening thoughts. We've covered a lot of terrain. I'll follow up with some targeted questions, but I think given the caliber of these folks, just hearing their opening reactions to the work and the issues that have come up is a great way to start. So Bruce, let's let you begin.
Great. Well, it's lovely to be here, and thanks to the John A. Hartford Foundation, and Health Affairs. And thanks to the presenters for a set of wonderful papers. So just at a high level, I think especially the panel discussion brought out one thing that's bothered me for a long time, and that is just a general lack of any coherent long-term care policy in the United States of America. We don't have it, so what you get is a lot of hybrids and Band-Aids and various things that don't quite compensate for a system such as Germany or a system such as Japan, where things are more ably put together. The other, and this comes from long experience, so I'm a geriatrician, I practice, I do health services research, is the notion of home and community-based care, that whole spectrum of care, is something that most health systems just absolutely, they just don't get it. They don't understand it. It's, I don't know if any of you have ever seen the video of the backward bicycle. Anyone? So your assignment tonight is to go onto YouTube. It's a 3-minute video, and a guy has engineers build him a bicycle that goes backwards. That is, when you turn the steering handles to the right, the wheel goes to the left. And he knew that he'd have to do something different. He understood this was a different bicycle, and he thought it would take him a few minutes or a week or so to learn how to ride it. And it took him 8 months of concentrated effort to ride that bicycle. He uses as a metaphor for the difference between understanding that behavior or something has to change and actually knowing how to do it is so damned hard sometimes, right? So hospitals are used to building buildings, systems are used to building buildings, putting people into beds and moving them through a system. And that's an overgeneralization. There are certainly many innovative and forward-thinking systems that do get this, but most do not, and the community is just a complete black box to them, whether it's an AIM model or independence at home or home-based primary care or home-based palliative care or capable models, and we can talk about all of those. So it's a countercultural model, and I think it's a key thing to keep in mind as these discussions happen, because as Alan noted, things are siloed, things are fragmented, and this just becomes the other place to most health systems. And a lot of payers aren't all that engaged in really thinking about it either. I've been amazed over the years how most payers will pass things along and move things down the line, but really haven't bellied up to the bar to make changes. I think that's starting to happen. We certainly see some leadership there emerging, but it really hasn't taken hold just yet. So those are some opening salvos.
Thank you. Ann.
So as Alan mentioned, I'm a primary care physician, so that means, I'm a very nice person. I tend to be polite, and I love the kind of conversation that we had this morning about data and research and evidence. But as Alan mentioned, I've also had a double life, working in state health policy and also for the last 4 years at a consumer health advocacy organization, where our mission is to make the healthcare system better meet the needs of consumers, patients, families, caregivers, who have really the most complex needs and who are low income. And I've learned through that work that being polite and nice and talking about data and research and evidence just isn't enough. When I think about what it's like to be old and poor and sick in America, it's not getting easier. And I think we need to really think about what is it going to take to change that and to improve the health of older adults. So, I think that requires us to start thinking differently, as Bruce alluded to. It requires us to think about power, who has power to create change, who has economic power. When I think in particular about the high rates of bankruptcy among older adults and also the new generation of caregivers that's giving up their own economic future in order to care for older adults, what does that mean for people's ability to age on their own terms? So I'm also interested in the intersection of class, race, and power. Who is seen, who is listened to, who are systems designed to serve? And so these, to me, are really the broad issues, and we see in the research some of the signs that all is not well and that there needs to be a lot of change in the system. So this seems, somewhat abstract and esoteric. How do you start to shift the power dynamic? I will say in the work that we've done at Community Catalyst, we've tried to systematically understand how do you organize individuals who are served by public programs, who are low income, who don't have a lot of power in the system. How do you bring them together? Can you reach them? We spent 2 years and about $1 million supporting state and local organizations, asking them to go out, find older adults, people with disabilities, people who are underserved, and ask them to get involved in changing the healthcare system. And I will say that we were able to reach about 30,000 people in 2 years. We were able to create policy and process changes in every state that we worked in. So we think that there is a precedent for systematically building that power to create change, but I think that also has to be part of the conversation.
Thanks. Tim.
Great. Thank you, Terry and the Hartford Foundation and Alan and Health Affairs. This is a very important conversation. Actually, as my comments will make it clear, it's, I think, one of the most important conversations that we need to have in the United States, not about healthcare, but just in the United States about anything. And I would also want to say that I, too, am a primary care doctor. Do I get credit for being a nice person for that? And actually, while I was sitting over there, I got a text from a daughter of a patient who's elderly and frail, and who I've been trying to encourage to move into our home-based palliative care program, which is not funded by any system except we fund it internally because we're an ACO and we know it's the right way to take care of patients. And she admitted her father to the hospital last night yet again, and her text this morning, just while I was sitting here, was, I know I've been putting this off. I think it's time to have that conversation because I don't think we want to go back to the hospital. I don't see that it's doing my father any good. By the way, the daughter is a physician herself. And then the last thing I wanted to say before I'm going to make 9 statements that I believe are factually correct from my perspective, but I'm in management now, not in research, so I get to assert anything, and whether or not I have the facts to back it up, who knows? So I have 3 statements of bad news, 3 of good news, and 3 challenges. So the bad news. The majority of the projected federal budget deficit is due to the cost of healthcare for our aging population. Full stop. So despite all the problems with the adequacy of our current system, from a purely financial perspective, we cannot keep caring for our elderly the way we are doing it now. Number 2, the care needs of our frail elderly population requires substantial human touch. So the digital healthcare revolution by itself will not solve this set of problems. Number 3, even lower rates of hospitalization among the elderly, even with lower rates of hospitalization among the elderly and all the home care services that we've been talking about, they will still require acute care services. And our community hospitals are closing at a substantial clip, meaning acute care is increasingly far from home for our elderly. Some good news. Payment models that encourage coordination of care among different types of care providers, ACOs, integrated delivery systems, et cetera, are demonstrating meaningful progress on improving care coordination and lowering costs. We need to push harder. Digital systems such as monitors and algorithms that mine electronic health records that identify decline or impending acute needs are clearly effective in helping caregivers efficiently allocate their time to respond to patients' needs and prevent decline. The jargon here is healthcare as a tech-enabled service. Number 3, biomedical advances are poised to make significant progress in treatments of dementia, cancer, and inflammatory diseases. So now my 3 challenges. The transition from responding to acute needs to preventing and supporting decline remains both an operational and cultural challenge. Number 2, incorporating effective novel technologies and advances in care delivery, the jargon here is redesigning the platform on which care is delivered, while simultaneously decreasing costs of care will be absolutely essential for our future. And number 3, the data on the importance of our social networks on our individual health, in a word, loneliness, something I see in so many of my elderly patients, suggests that our current policies and attitude toward work and families are a major contributor to premature disability and death. So those are my 9 statements.
Great. So I'd like to start my remarks by acknowledging the tremendous success of unprecedented population aging, which has allowed so many more people to reach old age in good health and to remain active in contributing to their families, to communities, and to society. With that said, the papers by Konetzka and Ornstein and the discussion today drive home the reality that the benefits of longer lives have not been distributed equally. And I want to thank the John A. Hartford Foundation and Health Affairs for providing this forum for a discussion around the more nuanced and complex aspects of aging and health. I'd like to make 3 interrelated points in my remarks. The first is that we as a society need to go farther in rationalizing the mismatch between the curative focus on the prevailing payment and delivery systems with the care needs of people who are aging with disability. The Great Society programs of Medicare and Medicaid originated in a very different time when life expectancy was about 10 years less than it is today, when few women worked outside the home, and when medical technologies had a much more limited ability to prolong life. The reality is that today most people are either underinsured or uninsured for long-term services and supports, and we've heard a lot of that in the discussion today, which on average accounts for hundreds of thousands of dollars for those who need these services. The challenge is that the lack of coverage for long-term services and supports robs those who are living with disability of access to basic care needs. It inhibits quality of life, and as we heard in the paper presented by Konetzka, it too often leads to additional services use, such as hospitalizations and emergency department visits that could have been avoidable if basic care needs were met. The second point is demonstrated by the Ornstein paper, which is that aging with disability and serious illness is overwhelmingly a family affair. There is a tremendous expectation that family caregivers are there to provide help with basic care needs, as well as bridge the fragmented service delivery environment, which spans settings of medical care, as well as multiple providers of care, specialists and generalists. And there's a large disconnect between the training and credentialing of medical professionals to function within a clearly defined scope of practice in highly regulated settings, with family caregivers who accidentally fall into their role and who are simply assumed to have the knowledge, the education, and the skills to provide whatever care is thrown their way. A recent study led by Julia Bergdorf and our group found that less than 1 in 10 family caregivers of older adults nationally had received any training related to their caregiving role. So in the absence of a movement towards shoring up long-term services and supports financing, I would say that there's a tremendous opportunity to better support the family caregiver workforce with additional acknowledgement, with assessment, with appropriate referrals, and with better supports so that they are able to have greater competence and confidence in their ability to provide care. I wanted to end on a more optimistic note, and my third point is to point to emerging areas of progress. There was a discussion earlier by Brad Stuart about the CMS payments for advanced care planning. There are new dementia care planning codes. These are all really very promising, rolling out at the federal level. I also want to point out that states have been real hubs of innovation in both experimenting with new models of long-term services and supports financing, as well as models of care that bridge health care delivery with long-term services and supports and bring in the aging network as well. These state initiatives are also helping family caregivers balance work and caregiving responsibilities. And 6 states in the District of Columbia have passed some version of paid family and medical leave. This is incredibly important because there are massive disparities in access to paid leave, with just 6% of the lowest wage earners having having access to paid family leave. We know that the individuals who are of lower socioeconomic status are most exposed to disability and to caregiving. So I know my time is almost out. I just want to sort of reiterate my point, which is, I think, picked up by many of the other comments, which is the importance of thinking about how to more effectively allocate constrained resources moving forward to really prioritize what's person and family centered, that prioritizes care, quality of life, and dignity.
Okay, that was a really phenomenal set of comments. Unlike Anna and Tim, I'm trained as a lawyer. No one's ever claimed that being a lawyer makes me a nice person, so I'm going to try to not play the role up here. It is challenging. I think we could spend the next 45 minutes talking about the negative consequences of the absence of a coherent long-term care strategy and policy, and lament that we don't have it, and we would all walk out feeling really good about how we've diagnosed the problem, but probably not very far along on solutions. So I'm going to try, even though I think I could get broad agreement on that topic, I'm going to try to take us a few steps short of that to see what we can do in the time we have and leave with some positive feelings, although I'm going to do it in a not as nice a way as a primary care doc would. So the first, so I just have a bunch of questions, and I can't help myself. Bruce, you said the health system just doesn't get it. And the first thing I thought of, aside from you're right, is this is the exact same conversation I feel like I'm hearing about the broader issue of social determinants of health, where we're saying to the health system, oh, by the way, all these people you're treating are sick for reasons that are broader than just what brought them to you today. And all the resources are getting eaten up by health care services, but if you could just figure out how to address these social determinants, that would improve everyone's health. And the health systems, I think many of them are saying, you're right, but by and large, they don't get it. I mean, this is not where they started. So my question to you and your co-panelists up here is, what does it take to close that gap?
Yeah, I think it takes a bit of it's not an easy question. It does take a bit of an adjustment. And I just finished reading Sir Michael Marmot's book called The Health Gap. I don't know if any of you know it. And that is an astonishing book. If you're interested in social determinants, he really puts all of the arguments together in a coherent way. And I wish I could remember more of it now as I'm sitting here. But I do think that one thing about engaging with patients and their caregivers in the community is that it does bring you face to face with social determinants. So, and it comes back also to power. So I'm also a nice primary care physician. And I won't remind Alan what Shakespeare said about lawyers. But when you go out on a house call, the power equation changes completely. You're a guest, and it's important to be a good guest. So I'm not in the clinic wearing a tie and or a lab coat, which I never wear in clinic anyway, but I'm not wearing that kind of armor that people wear in healthcare settings. And I enter someone's home and I see the social determinants. I am forced to confront them. I don't always have the tools I need to address them, but it really throws it in our face. And that's where I first learned, wow, wouldn't it be nice to have a social worker? What can a physical therapist do? What can a handyman do around the house to make this place a little bit more accessible and improve the ability for someone to function? So even though health systems don't necessarily want to assume the responsibility of social determinants, there's a lot they can get a lot of juice out of the fruit if they just did a little bit. And those differences could have very important consequences in terms of health service utilization, on the experience of caregivers. on issues related to loneliness and social networking. So I don't think you have to change the whole world to make substantial improvement here, but I would love to hear what others think of that.
Other thoughts on this? I've got more questions, but if you... All right, I'm going to take you up on raising the issue of class, race, and power, and I'm going to pose a question in a very pointed way, not just to push and hope that it sparks some response. So we heard from Brad about a very interesting, important program that reallocates resources. And Tim gave us a number of challenges, and also from the perspective of his system about what we can do. Jennifer ended with various models that we have of reallocating resources. So one way of thinking about those is these are all incredible models and mechanisms for pushing a health system that tends to want to continue to do things the same way it always has, to be more responsive to patient needs, which is what your mission is. That's one way. Now let me take it a different way, which is all of these models are about keeping the money in the healthcare powerhouse, Sutter, Partners, just to pick on two, but believe me, the list is a lot longer than that. And while they create opportunities for reallocation, the power choices for how to reallocate still rest in these very highly resourced institutions that may or may not, depending on mission and all of these other things, really be responsive to the disparities associated with class, race, and power that you raise. So which is this? Is this, and I know this is not, but I'm just trying to push a little. Is it terrific, or is it not really what we need if we're going to get where we need to go?
Yeah, no, I think I think that this is a great question. I mean, I think changes in payment, changes in delivery, they are important but not sufficient to achieve person-centered care. So I think there are. You still need to ensure that there's a very, very strong consumer voice. You need to ensure that you're reducing disparities in these models, and I think a lot of times the data tends to lag as to whether we're getting better or not getting better in that regard. And also, I think people have differential access. I think about the patient population that I take care of. They have access. There are a lot of interventions that are just not possible if you can't get to where you need to go, if you don't have minutes on your phone, if you don't have a family member who can help you out in a pinch. There's a lot of barriers to access that aren't necessarily going to be resolved by themselves unless someone consciously thinks about them. So I think they're an important step, but they're not sufficient. In terms of the resource allocation issue, I do think there are some interesting examples that could serve as models where resource allocation decisions have community voice built in. I think, the one that comes to mind is certainly Oregon's, the way they've constructed their coordinated care organizations to have a link to what communities prioritize as their most important issues to address. So I do think there are some models for better systematizing and normalizing that as the force that drives allocation decisions.
So I didn't mean this to be like one question for each of you, so I want to encourage others of you to weigh in on this. Tim?
Well, I'm glad you raised the question. It's a very challenging one. I'm going to, since you decided to be provocative, I'll maybe be a little provocative back and say, so we have entire agencies, wings of our state and federal governments who are dedicated to trying to solve the problems of the social determinants of health. We call them housing agencies. We call them home care agencies. We call them all the things that actually are not part of our health system. And when I hear people talk about the health system needs to take more responsibility for those things, I'm thinking, well, maybe the people who allocate the funding should put more of the funding in the social systems, because I'm not sure doctors are the right people to be advocating for housing. How does that work? I have no idea how to do that. I'm sure people have some very good idea about that. So I worry a bit about pushing health systems to take on more of a responsibility where they're not actually experts at delivering within those sectors. But having said that, it is also true that they are connected. And treating it as a separate silo would also be a problem. And I have the honor of sitting on the board of the National Health Service in England. And I will say, they are facing the same, people think about, single payer, it solves all the problems. It doesn't. They actually have many of the very same problems. But one thing that's interesting about their set of problems is they are able, because they are increasingly have identified this continuum and the importance of continuity across these different silos, of regulating those silos in a uniform way. So it is still the housing people who deliver the housing because they're better at that. It's not the healthcare people. But they are increasingly enforcing a regimen and an organizational structure that creates accountability among silos. That's a very hard thing to pull off on an operational basis, to be clear. But it seems to me we should be heading more in that direction, that would be a productive direction to head in.
Great. Jennifer?
Sure. So I guess to respond to your first comment and the second comment in terms of what would it take to make change, I guess I have several thoughts, including I guess recognizing that we've sort of moved a long way towards living longer with chronic illness, and there's this clear recognition that moving towards person-centered care requires interacting with individuals and understanding and respecting their wishes, which suggests the need for incrementalism and really working with people and understanding where they are in their lives and ensuring that they get the services that they need at the time that they want. So I think that speaks towards sort of incrementalism, but yet we are also in a time where we have more data than we've ever had possible from a variety of settings, social service agencies, from long-term services and supports providers, from healthcare providers. There's rapid technological innovation, which allows us to think about all kinds of new ways of delivering services and incorporating perspectives from individuals and their families and their social networks. I also think that we are in a time where there's real change in thinking about how we do research. And there's an appreciation that we need to do research differently. We need to have different partners. We need to be developing models of care that are embedded in practice. And I think there's multiple federal agencies, the National Institute on Aging, AHRQ, have all really shifted how they are, the funding mechanisms to prioritize research that is poised for translation and for dissemination and for sustainability. And I think that really opens up the opportunity for new partners to be at the table so that health systems and social service providers are working together and we can learn real time and then disseminate models that are proven to be successful and that look at multiple endpoints that are important to people and their families, but that are also important to the decision makers who have the authority about whether to take up an innovation and make it work in the real world.
That's great. I have another question, but I have another one, or if you want to jump. Okay. So I want to think optimistically about where we can go with this, and this is sort of an odd way to be optimistic, but I'm going to say it nonetheless, which is that despite the fact that we need to address issues of class, race, and power to make change, it's also the case that in the United States, change usually arises when there's a middle-class movement. We are not so great at poor people movements over the generations, although we've had some very successful ones. But what I'm struck by, and this is why I say it's a little bit odd, is that this system sucks for middle-class people, and therefore this is not a situation where there's only a small share of the population who's really suffering the consequences of our absence of a coherent strategy or policy, where everyone is, almost everyone. It's very hard either through good luck around health or incredibly high resources to opt out of this. So my question is, how do we harness Well, I guess my first question is, are the issues facing the middle class similar enough or across economic strata that we could think of this as a coherent or a unified front in trying to achieve change? But how do we harness the fact that this is a problem for so many people to accelerate the rate of change that all of you have said there's some real positive change going on? How do we?
I'll start more with so I think there should be a way to harness that power, but I would say that most people don't understand enough about what they're facing to get activated. Mm-hmm. So in my clinic, I take care of mostly, in my outpatient clinic, it's, I'd say poor to lower middle class mostly, and then occasionally some very well-heeled people who are very smart, professors and academicians, and they have no clue that Medicare doesn't pay for home health aides. They have no clue that Medicare does not have a long-term care benefit. So it's hard to get people activated when they think they have benefits coming their way that they don't know are absent. So, and it's not, I think, because of a lack of people trying to get that message across. I think part of this is wrapped up in people's denial of aging and need and those types of things. So I think there's probably a coalition to be built around this, but it's hard to get people to be that future focused. They get that future focused when their mom or their dad or their loved one is in that boat, and they're in that boat with them, and they say, who's here to help me? And they can't find those resources. So.
Yeah, I'd like to say that the group that has not been mentioned today is AARP. And what AARP has done for the CARE Act and what they've done around the RAISE Act and what they're thinking about in terms of activation is extraordinary. And groups like NIC that have thought about how housing should be used as a vehicle for good is another example. And what that means is that we, as a community of scholars and leaders, have got to do a better job knitting these conversations together. As somebody who works with IHI, the Institute for Healthcare Improvement, in their national and global work, and EDC, the Education Development Center in Newton, Massachusetts, that is also global, when you work with those groups, they stream it better than any health system ever will.
I think that's just echoing everything that Terry just said. I think the education issue is huge. I do think there's some opportunity to make common cause, especially around the important role of Medicaid, also as a source of coverage for caregivers, right? So when people are caregiving, both Medicaid and also subsidized programs become very, very important. So I think there are some opportunities to think broadly, and I think particularly about the support for caregivers. But I think there's a lot of denial, and I think that's what we're seeing as people hit post-retirement and suddenly realize that they're paying way more out for Medicare out of pocket than they ever thought they would. And then on top of that, they're not able to access the home health aides and personal care assistance that they need in order to stay independent.
Jennifer?
Yeah, I guess I just will chime in and say I think there's a tremendous sort of a public awareness problem. There's a disconnect. I mean, there's a lot of certainly an optimistic messaging around longer lives and aging well. But there is much more. There's a problem, a sort of a communication problem around aging with disability, that many people are, barely working class people are certainly often focusing on meeting their daily needs with and with their finances, and certainly not able to plan for retirement, much less long-term services and supports needs. So I think there's an awareness problem. There also, I think, is a tendency for us as a society to talk about individualism and to try to sort of just push through and to not ask for help. And there is, I think, needs to be messaging around a greater sort of awareness of a collective, having a collective to support people who are living with disability as sort of a societal, something that is we as a society need to, I guess, embrace and think about how to develop policies and programs such as the Raise Family Caregiver Act, and I think that provides a mechanism to think about a strategy, but we also need to be simultaneously thinking about communication and messaging. I think that speaks to Terry's point about AARP and some of the other organizations who are in this space that are not researchers and not primary care physicians, but also have a lot that they could bring to the table.
Okay, so I'll soon turn to you all, but I want to make sure we pivot in a direction. It's hard not to get a little stuck with all this, but I'd like to hear what you think is the most encouraging development that you observe in the real world, not in some theoretical world, that's moving us toward the kind of age-friendly systems that meet the needs of the people we're talking about and the people we serve. What is the most promising development? Anyone can go first. Tim.
I think my caveat for this statement is that probably if you asked me this tomorrow, I'd have a completely different answer. So this is just the one that comes to mind. But it's the one I've been very personally involved with, which is alternative payment models at the health system level. And, it is interesting when you are part of a very large organization that delivers healthcare services, and you wake up one morning and you have, say, $100 million in downside risk for taking care of a population of 100,000 people. You start to think that maybe we're not designed optimally to do that. And you start making decisions about how you will deliver care going forward. And even though you're not being paid to deliver certain types of care, you realize you should be delivering that care because of the cap that's been put on your total income. And addressing the kinds of problems that have been discussed here and then the problems immediately becomes your highest priority. Because as Brad's slide showed, that is where all the money is. That is where all the money is being spent, and that is where a lot of money is being spent unproductively. And so if you are going to manage a whole population, you are going to start with the frail elderly. And you are then going to build all of the programs which wonderful health services researchers and all the publications of Bruce's that I've been reading for should I say how many years I've been reading your publications for? Yeah. Who first introduced me to this a long time ago. You suddenly start taking that research and saying, wow, someone has actually, published a paper in which they showed on a small scale that this works. That's exactly what I need, because that's what I need to put in place at a big scale. And so, so I now practice in a health system where I can't imagine going someplace else because of the resources that I can now give to my patients. Those resources are not paid for under any insurance plan or under any benefit. They are paid for simply because a change in the payment model created new incentives within the health system to think differently about the delivery of care. I am obviously very optimistic about that.
I doubt that answer is going to be different tomorrow. That was clearly quite thought through.
Yeah, just to segue onto Tim, so the thing I'm encouraged about building on that is the ability of these models to start to promote the scaling of models that we know, and just a few near and dear to my heart. So one is hospital at home. So actually doing acute hospital care in the home as a substitute for doing it in the bricks and mortar of the hospital. A pile of evidence from dozens of randomized controlled trials around the world that this model is better care, higher quality care, associated with marked reductions in mortality if you're taking care of at home rather than the hospital. So one of our statistics that we health services researchers geek out about is number needed to treat. So the number needed to treat with X intervention to prevent an outcome. The number needed to treat for hospital at home to prevent a death is 50. That's astonishingly low. If any of you are on a statin, the number needed to treat to prevent your heart attack is much higher. I mean, that's a really astonishing statistic. And if that were a drug, right, if hospital at home were a pill, or an implantable defibrillator or something like that, it would have been widely scaled a long time ago, and I wouldn't be here. I'd be sitting on the beach in the Caymans counting a lot of dollars. But that model is starting to get picked up. It's being now implemented by commercial entities. Tens of millions of dollars are entering that space to get it scaled. Home-based primary care, sort of an adjunct in some ways to the AIM model. You have large home-based primary care entities that are now delivering care at scale and saving money. So one example is a company called USMM, US Medical Management, based in Troy, Michigan. One of the largest ones, has an average daily census of about 30 or 40,000 people. A few years back, they formed the only, to my knowledge, the only home-based primary care only ACO. In 2017, they were the 4th most successful ACO in the United States in terms of saving money for CMS. Why? Because it targets, right? You can only save money on people who cost money, who have preventable cost, right? Independence at home, which Brad mentioned. Home-based primary care, Independence at Home, a CMS demo under the Affordable Care Act, saving 10 times the amount that your average ACO is saving. And one last model I'll mention is a model called Capable, led by a dear colleague, Sarah Zanton, based at Hopkins, nurse PhD. And Sarah came to me a few years ago and said, I have a model that's actually going to improve function for people in the community. And I said, Sarah, nothing improves function. Nothing improves function. So this is a model targeted at community dwelling, dually eligible, Medicare and Medicaid eligible folks in the community who are functionally impaired. And it's a time-limited intervention of a nurse, occupational therapist, and a handyman. And the secret sauce is that Sarah's been able to train people to truly get at their goals. So handyman doesn't go in and change the whole house, but if the person says, I'd like to be able to walk out to my mailbox, but there's no rail on the front 3 steps, handyman will put in the rail. That model improves function astonishingly and also saves money for Medicare and Medicaid, and is now being implemented by a number of state Medicaid plans. So those kinds of implementations make me optimistic. We need much more of it, much more of it. Changing service delivery is so much harder than many other things.
It's gratifying how many of those you referred to we've published.
I was going to say 2 things very quickly. One is I think there's some really interesting state-based initiatives around long-term care and support for caregivers. I know we're not supposed to talk too much about that, but I think the innovation happening at the state level is really promising, and I think something that we're very, very interested in learning more about and seeing if that could be something that gets pushed in other places. And then I would say, more locally, I think the thing that I'm most excited about is older adults being very activated and interested in engaging in conversations about new models of care and how to improve them.
So I am most excited about age-friendly health systems and the fact that working with incredible leaders in geriatrics and gerontology with health system leaders, we have created a model that focuses around 4 M's. And you've heard them all today. What matters to the older person, mentation, their cognition, medications, and mobility, which we just heard about. If you fundamentally get those 4 things right, you will get exponentially the next 35 things right, because it has to be done as a set. All of these things are interactive at all times. And what we've heard from our panelists today and our scholars who presented papers is this need to create a set, a way of thinking about set. And so the Institute for Healthcare Improvement has done an extraordinary job in helping us work on this, and stay tuned as we continue to move it around the United States and across the globe.
Great.
Can I just build on
Yeah.
age-friendly for a moment? I didn't talk about age-friendly, which I'm very excited because I knew Terry would talk about that. But I think one thing that's spectacular about age-friendly is that it really gets to the notion of culture change, right? There have been CMS demos, and I forget the initials that go with it, when they were very focused on preventing certain bad outcomes in hospitals, which are really important. So preventing catheter-associated urinary tract infection and bloodstream infections. And I think a lot of what tends to happen there is that systems go in search of a widget they can buy and plug into their system to prevent that one outcome, when in fact something like age-friendly really starts to go both wide and deep on culture change, which has to happen to improve outcomes over time. That's really important. It's not just focusing on the one, it's focusing on the whole culture of care delivery.
Okay, time for you. We have microphones. Please wait. We have a lot of people watching this, and we'll record it as well. So right up here in the front, I'm going to swing my way across here.
Thanks so much. Kevin Bison, emergency medicine physician at the University of North Carolina. Work closely with John A. Hartford and West Health on geriatric emergency departments and new delivery models of acute care. My question is about boiling the ocean, a metaphor that I'm increasingly uncomfortable using, as I'm afraid we may be doing precisely that. But that's a different panel. So I would love the panel's thoughts on, there's an overtone of, gosh, we really need to be putting more funding in long-term social supports. Absolutely. However, how do we precisely deliver that at a moment when it would potentially both increase the quality of life and at least pay some attention to making sure that the resources are given where they're most needed and have therefore less increased cost, right, if the alternative is more expensive? How do we do that? Because the resources are not unlimited, and for better or worse, the culture we live in the United States is not as socially supportive as some of the analogous countries and the other OECD countries. My proposed, just a little plug, we're focused on emergency acute care, and basically the hypothesis is that when an older adult raises their hand and needs additional help, that's a great moment to come in and look at alternative deployment strategies as opposed to hospitalization, and not just be reactive, oh no, they fell, but proactive. Do they need something in their house to help them not fall next week? Do we do medication reconciliation? Do we work with the 4Ms? So acute care is one way to do that, and we have 98 geriatric accredited emergency departments across the country now, as opposed to a year ago, so we're making great progress, but there's another 4,400 to go. So acute care is one way to do that. What are the panel's thoughts on other ways to get the resources at that moment when we can positively change the care and cost trajectory of those patients, thereby making these programs sustainable?
Who wants to take that on? Jennifer, you look ready to go.
Well, I intentionally did not chime in on your last question about, I didn't have anything to add because I think all of the comments, and particularly the payment models, is so important in driving innovation. And I think that relates to the point that was just made in terms of thinking about how do we rationally allocate resources and prioritize long-term services and supports. There is a body of evidence showing that people who have long-term services and supports and who have unmet care needs incur higher healthcare costs. A paper that our team just published in May found that among older adults with self-care disability, those who had unmet care needs incurred $3,200 more to Medicare relative to their counterparts who did not have unmet care needs. And the silos of funding have really inhibited the ability to think about how to provide integrated high-quality care. So the alternative payment models that are moving forward, I think, provide a natural incentive for innovation within care delivery systems, within states, that prioritize identifying people with care needs upstream, assessing their functioning, as was mentioned earlier, both for older adults as well as those who rely on family and other unpaid caregivers for their care needs, to have an assessment of what their situation is and to provide care proactively that's person and family centered to keep them out of the emergency department.
Yeah, just building on that notion of integration, there was a terrific study from University of Pennsylvania published in the Journal of the American Geriatric Society recently, where they looked at folks who were eligible for independence at home, who were getting typical primary care, although sometimes hard because these people are mostly homebound, compared to people who are getting care from an independence at home practice, so home-based primary care. Then the third group was independence at home integrated care planning with long-term social support services from the local area agency on aging. What you found is that, when you went from office-based care to independence at home care, you cut hospitalizations in half or rather substantially. When you then add integrated care planning with long-term social support services, you don't reduce hospitalizations anymore, but you cut long-term institutionalization rates in half, right? So the ability to integrate and do, just cross the boundary between Medicare and Medicaid dollars, do some proactive care planning, you can keep people out of long-term institutionalization. So totally reinforces what Jennifer commented on.
Tim?
Well, I wanted to try to articulate, so if we know all these great models that have been so successful and they're published in great journals like Health Affairs, and yet, so why, and we also know the payment models that are relatively successful at scaling them, why aren't we making more progress? And I want to put out a hypothesis about that, and it has to do with, and so I'm going to be way out over my ski tips here and practice economics without a license. And that is that, our fee-for-service payment system, fee-for-service is often pilloried as the root of all evil. It's not the root of all evil from my perspective. Fee-for-service is perfectly well designed to pay for anything that is easily defined. If you listen to the conversation we've been having for the past several hours, almost all of the services that we've been describing are not easily defined. They're actually, by definition, very difficult to define. So then, there's actually only two ways to pay for things. There's fee-for-service, and then there's some sort of cap, some sort of set, where you get paid a certain amount. The problem from all the perspective of all the people who pay for healthcare is when they give a check to someone for a diffuse set of services that varies by person and everything, the room for fraud and abuse is extraordinary. I'm just going to say it because this is what the lawyers at CMS have told me about their problem with paying for this stuff, which is, how do you pay someone to do a service when you don't have a discrete way to audit the fact that they're doing their job? And that presents a real challenge. I will say that presents a real challenge in our system, and it presents a real challenge in all those European systems, because at the end of the day, you have to pay people to get work done. And what we're asking them to do is not deliver a discrete service, it's to coordinate the services. And so if any silo you pay in, however you pay it, what incentive do you have to work with people who are being paid in a different silo? That's a real challenge. And I've seen some models that attempt to overcome that. But I will say the problem with scaling all of our great interventions is that great people with high degree of motivation are doing those interventions and publishing them. But that doesn't necessarily mean that the incentives that created them to innovate and do all this good work are going to exist when you scale it and pay for it generally. And I know that, sorry, a patient, that's
you can ignore it. It's okay.
That's a big problem that we face on the PTAC when we are evaluating new models of payment. That has to be part of our thinking of what are the strategies to mitigate the misallocation of these funds. So I just want, it's sort of a dose of, sorry if that was cold.
No, and I'm just going to say, I've spoken often about the origin, since you talked about the financing coming through accountable care organization model, the origin of that was systems wanting to reallocate, feeling like the payment model was a barrier. That's very different than changing the payment model to encourage or force organizations to deliver care differently. These are two, and what works for one may well not work at all for the other. Let's try to get a couple more in. I see two back here. We'll take you right here in the center, and we'll get both of you in the center, and then we'll see how we're doing. But let's try to make it quick questions and answers so that we can get you out of here. Go ahead. You have a microphone. Go ahead.
Okay. This is a question for Dr. Ferris, but I welcome feedback from the rest of the panel. I'm Mari Savickas. I'm with the College for Healthcare Information Management Executives, a mouthful, otherwise known as CHIME. We represent CIOs and others in the C-suite who purchase and deploy technology for healthcare providers, so mostly acute, but we do have members in the post-acute care and long-term care settings. One of the things I hear from our members who are in the LTPAC setting is that they can't get the CCD, which is the summary of care sent electronically from the hospital in a timely fashion. And so I've heard a lot of talk about ACOs, a fee for service. I'm not a payment expert, but I'm trying to figure out like how to move that needle forward. How do we get it such that the hospitals do it and there's not like what I would call the sledgehammer to kill an ant approach where you come down very heavy-handed in a punitive manner from a payment policy perspective on the hospitals and encourage and foster more collaboration among these settings such that the care handoff happens very quickly. They tell us that it happens, they get the CCDs if they get them 3 to 5 days later, and they actually need them ideally before the point of care so that they can get it before, say my mother-in-law comes in on a gurney. They need to know about her before she arrives. So anything that we can do as CHIME to help spur that conversation forward, we're all ears, number one. Number two, CHIME's a member of the LTPAC, more acronyms too, but bear with me, the LTPAC Health IT Collaborative. And so I would welcome anyone to, come to approach me. We do this because we think it's the right thing to do, and we're a bunch of folks who care about the LTPAC space, but from a technology standpoint. So any comments you can make about fostering technology innovation, facilitating that care handoff in a very collaborative manner, I'm all ears.
So I know that the other people up here also can address this question. I know Bruce does a lot of this. This is one big place where the advantage of the National Health Service in England is a big advantage over us, because actually they do control the whole thing. And so there are a lot of regulatory barriers. These are not technical barriers, these are regulatory barriers to exchange of information. And we can't get out of our own way in the regulatory barriers. The technology is easy. And the interconnectivity is easy. It is now. It didn't used to be just a short time ago, but it's really easy now. But mostly what impairs timely communication of available electronic information are regulatory barriers. And I am the last person to speak about the soup of regulatory barriers. If it comes up in conversation, I usually walk the other way. So, and I'm sorry to say, it's sort of a mess, but our lawyers are constantly telling us, can't do that, can't do that, can't do that, even though we can say this is being done in the interests of better patient care. So that's not a very hopeful answer. Maybe others can be more hopeful.
Get new lawyers. Let's see if we can get the question that was here in the middle, and I think we're probably going to be out of time at that point. We do try to end on time. So.
Yeah, I think there's 2 minutes left. My name is Mallory, and I'm with the Coalition for Disability Health Equity. And I wanted to talk a little bit about, Bruce, you were talking about the Capable program and how it's a nurse, an occupational therapist, and a handyman. And if I'm correct, you had said that nothing addresses function or nothing improves function.
Yeah, more in the context of care interventions for older adults. It was not specifically focused on the disability community per se, but there have been lots of tries to improve, for interventions to improve functional basic ADLs, IADLs for older adults, and for the most part, the literature is pretty negative, right? Yeah.
So as an occupational therapist, I just wanted to make sure that you were looking at the occupational therapy perspective. I'm very happy to see nurses, public health officials up here, but primarily I'm seeing mostly MDs, and I wanted to ensure that all of your research and your work is integrating other clinicians as well, physical therapists, occupational therapists, because there is a good base of evidence in regards to occupational therapy increasing function, because that is specifically our scope of practice and exactly what we do for work. So my question was, how are you making sure that you are including clinicians into your research?
I would say the answer to that is HRSA, Health Resources and Services Administration's GWEP program, Geriatric Workforce Enhancement Program, certainly encompasses you, your colleagues, and the array of our team members. And they're working on the 4Ms and age-friendly health systems in their work, which includes you. Thanks.
So I know there are more questions. That's sort of a good thing. That's why we get more articles published, because they haven't all been answered. This was a spectacular panel, lots of perspectives. Also, I think a nice balance of the challenges we face, which are very real, but some very exciting developments that can and should be built upon and are being built upon. And I think it's important we come away with that understanding. With thanks to the John A. Hartford Foundation, Terry, with thanks to you personally for the role you've played today, please join me in thanking our final panel.